Hello, everyone, and welcome to this audio podcast. This audio podcast as part of a Biome edition. This audio podcast is part of a Phantom Newscast. This audio podcast as part of a Lobostics Vortex. This audio podcast as part of a Storm Lobostics production. So, as part of this, as part of this, in part of this edition, this Biome edition, this audio podcast will go into a research poster presentation, a research poster presentation that a research poster presentation that was that formed that formed a poster presentation as part of the remit within the Japanese Society of Nephrology, the JSN, in 2022. The research poster presentation looks at polypharmacy and the influence of renal insufficiency, and the influence and polypharmacy and influence on renal insufficiency, and the research poster presentation looks at an outline in regard to a retrospective systematic review. The research was a collaboration between two academic institutions in the United Kingdom. Sort of before also to inform listeners that excuse me, just before the research poster presentation, the published works in regard to this systematic review had been and is also is and had also been completed in around sort of late 2021 and late 2021, early 2022. And so in this research poster presentation, as part of this audio podcast, looking at this works within the remit of the Japanese Society of Nephrology, or JSN, for 2022. So the aims around this was where the systematic review appraised, or sought to appraise sort of literature, sort of a review of appraise and review literature looking at the influence of polypharmacy on renal insufficiency in in older people, and look to explore the following questions. And so before going on, listeners, this research presentation also is in some ways sort of a follow on, if you like, of an audio podcast as part of an audio podcast as part of the media edition, part of a media edition that looked at works looked at a research poster presentation surrounding polypharmacy and technology that had been presented at a data science symposium in 2019. In this research, and this where and so thus in this research poster presentation, it is where this research poster presentation sort of delves into the works into the works looking at polypharmacy influence of polypharmacy on renal insufficiency, and looks at this in more of a systematic, in a sort of a more of a systematic on a more systematic on a more systematic basis. So the questions posed in this works as part of the aims was three questions. Number one, should there be smarter medicines management to reduce polypharmacy in older people? Number two, can tech be used to determine who should be screened for renal insufficiency if toxic drugs are if toxic drugs, for example, are overprescribed? And three, what are the advantages of tech that incorporates algorithms in collaborative working? So a bit of background, in regard in and as part of this. Excuse me. Excuse me. So between 2005 and 2015, percentage of individuals over 65 years of age in the United Kingdom had increased just over around 20%. The age group that saw the greatest percentage increase was those in over 85 years, which increased by just under 33%, representing about 300,000 people. Representing about just under 300,000 people, according to published works by Age UK in 2017, and amongst works, published works in 2019 by NHS England. So the number of people over the age of 85 years is and had been projected to double between had been projected to double between 2012 and 2032. There are incidence of comorbidities, for example, increases in older individuals, and it has been reported that individuals over the age of 65 years experience can experience four or more chronic illnesses at least 2/3 of the lifetime. As each illness can be treated with a range of medications. For example, the total number of drugs or the total number of drugs or pharmacotherapy that an individual can take on a daily basis can be high. And there's really just to additionally inform here, or as part of the evidence, part of the evidence, if you like. There's really informative works by Druden and team in 2013 and Schmidt and team in 2019. Many commonly sort of prescribed and even sort of what I refer to as OTC drugs or OTC drugs or medications, so over the counter sort of medications, as well as supplements, herbal remedies, and natural products, natural products, herbal remedies and natural products in at least some on at least some basis can contribute to nephrotoxicity when taken, and when the risks increase further when several are being taken together. So preventing over prescription overprescription is and has therefore has been especially important for older people who have an increased probability of developing renal insufficiency and leading into CKD or chronic kidney disease. Now, a little bit in regard to the systematic review approach as part of this research poster presentation from 2022. So to begin with some justification. So the justification for including people older than 65 years as elderly care is based on NHS England's definitions provided by improving care for older people and providing care for older people and sort of the an older people sort of NHS guideline from 2019 and our growing older population a guideline from Age UK from 2017. In around the search strategy, as part of the literature appraisal, a retrospective systematic review was conducted over a 21-year duration. The critical appraisal skills, a critical appraisal skills program or CASP, was utilized to appraise papers methodically and so main terminologies were arranged according to grouping of terminologies surrounding technology. Number one, technology. Two, polypharmacy, and three primary care. In amongst the research poster presentation, there is a list of the main terminologies, the databases used, the inclusion and exclusion criteria, and then a sort of an outline in regard to the common causes of estimated glomerular filtration rate changes. And as part of this audio podcast, there will be a look into those and the at the same time guidance from a publication a publication by author Harrison and team from 2017 and looking at systematic reviews, Center for Reviews and Dissemination, and works by Harrison and team from 2017 and a sort of a sort of addition an added guideline referred to as systematic reviews systematic reviews and Center for Reviews and Dissemination from 2008 were sought to reduce a risk of bias and include risk of bias and including non-randomized investigations. In around the data extraction, extraction and synthesis. So from 1,506 publications identified through several databases, 1,491 publication or publications or papers where duplicates were identified had been removed, and 44 papers or publications were further scrutinized after after removing duplicates and for integrity and relevance according to the terminologies. Records record guidelines, frameworks, policy reports that did not focus on renal insufficiency but had a focus on long-standing conditions and the National Health Service or NHS were further uh, uh, were, f- uh, were further were further excluded, and a number of which included six full text articles and reports were assessed for eligibility, and where the number was in around 32 full text articles that were omitted with uh, with uh, with um, with 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 some sort of unrequired explanations were and included nine, and then full text articles and reports that were further scrutinized using the critical appraisal skills program, or CSP. 23 papers or publications were included, and six themes were derived. Six themes were derived, and six themes were derived before going into the before going into the characteristics of investigations and the themes derived. As part of this research presentation, just a look at the main terminologies, the list of databases, and some of the number of publications identified in amongst the different databases, and a little bit in regard to the inclusion and exclusion criteria. So, in part of the main terminologies were in three categories as polypharmacy, technology, and primary care. In amongst polypharmacy, terminologies included healthcare professional, um, healthcare professionals, multimorbidity, comorbidity, inappropriate prescribing, overprescribing, safety, compliance, medicines management, pharmacy, and chronic illness management. In around tech or technology, the terminologies included interoperability, electronic patient records, integration, control, efficiency, data collection, protection, point of care testing, screening, and disease trends. In regard to primary care, terminologies under primary care, elderly, commissioning, National Health Service or NHS, chronic kidney disease or CKD, multidisciplinary team, monitoring, clinical commissioning groups, renal insufficiency, cost benefit, and prevention. Now, as part of the initial aspects of this of the systematic review, terminology between the different grouping of main terms had been had been had been had been had been associated or assorted in different ways through the different databases to identify at least initially some of the publications, publications. Hence, why initially through the data extraction and synthesis, through data extraction and synthesis, initially there have been over 1,500 papers or publications identified according to the general theme around around this research poster presentation. So, and again, looking at polypharmacy and influence on renal insufficiency, and then as part of this as well to additionally inform that the terminologies described were utilized in more than again just were again to inform were utilized in more than one combination of each other, so that a maximum number of publications could be identified accordingly. In a second table, as part of this research poster presentation, there is a list of databases. So in the databases list there are, for example, Embase, PubMed, Medline, Embase, PubMed, Medline, EBSCOhost, Web of Science, Cinahl Plus, that's CINAHL Plus, Cochrane Library, Wiley and Blackwell, Scopus, SciFinder, SciFinder Scholar, Biomed Central, and Science Direct. Now, in amongst the databases, and part of the list of databases, or with the list of databases, there are a number of papers that had been initially identified. That had been identified. Between 1990 and 2011, where between 1990 and 2011, thus over the 21-year duration, 21-year duration retrospectively. So in and through Embase, 52 publications had been identified. Through PubMed, 322 publications had been identified. In Medline, 28 publications had been identified. EBSCOhost, 622 publications had been identified. Web of Science, 15 publications had been identified. With Cinahl Plus, as 44 publications have been identified. Cochrane Library, 28 publications have been identified. Wiley and Blackwell, there were 102 publications identified. In Scopus, 172 publications identified. And in SciFinder Scholar, 27 publications were identified. Biomed Central, 49 publications had been identified, and Science Direct, 45 publications had been identified. So a list of databases were used to and again to identify literature, and then again a combination of the terminologies as outlined were implemented to perform the sort of the to perform the sort of main sort of search. Now, in regard to in as part of the inclusion and exclusion criteria now. So the inclusion criteria included publications or papers that included polypharmacy, acute kidney injury, chronic kidney disease, biomarkers, prevalence, cost benefit, screening, medicines management, and technology. Papers that are highlighted multi-centered were included. All papers that related to humans or the human population and included the adult amongst the adult population were included. Acute kidney injury and CKD related guidelines, frameworks, policy reports were included. Papers that surrounding technology and integration were also included, and included papers or publications where elderly age definition related 65 years or older, as part of NHS England's 2009 as part of published works by NHS England in 2019 and Age UK from 2017. In as part of the exclusion criteria, papers published in any language in any language except English. Were excluded. Duplicate papers across different databases were excluded. All papers dated before 1990 were excluded. Guidelines, frameworks, policy reports that did not have a focus on renal insufficiency but included those that had a focus on long-term health and NHS were excluded. Frameworks and guidelines where for example social support was the only primary outcome were excluded. um, uh, opinion book and industry and commentary publications were all excluded. Learning disabilities in this, at least in part of this works in this works were excluded. And papers that focused on renal transplantation or transplantation were also excluded. Now looking into the sort of characteristics of studies of studies and themes derived. So 6 themes were derived from this retrospective systematic review, including 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 theme 1, renal insufficiency interventions in elderly care. Theme 2, cost benefit of polypharmacy detection on renal insufficiency in elderly care. Theme 3, polypharmacy dose adjustments and medicines management in elderly care. Theme 4, technology integration to identify renal insufficiency for elderly care. Theme 5, biomarkers to detect renal insufficiency in elderly care. And theme 6, the role of education and healthcare professionals for elderly care. So in around theme 1, so although research had not investigated the sort of full causations of CKD or chronic kidney disease, emphasis on the significance of using the sort of correct one, the correct sort of causations to identify renal insufficiency in elderly care needs to be made. In addition, due to reduced in amongst the elderly, where the elderly are concerned, where there can be evidence of reduced muscle mass. For example, the elderly is or are higher risk of developing a drug-induced renal insufficiency. Increased incidence of associated illnesses among elderly improves susceptibility to renal insufficiency. Quality and patient results drive the efficiency of the NHS. Care home managers, or nursing care home managers and elderly care employees are invaluable in ensuring that the right medication reaches the right patient who need to be supplied with the required additionally who are required to have within environs where healthcare professionals are required data in around how to how to how to use how to ensure the treatments are used effectively. Approximately 7% of all admissions to UK hospitals arise from adverse effects of prescription-based medicines. This includes inappropriate medication taking by patients, and about half of the individuals do not, in fact, in fact adhere to prescribed regimens, and wastage from unused prescribed medicines is estimated to cost almost 100 million every year in the United Kingdom. In around theme two, looking at sort of cost benefit of polypharmacy detection on renal insufficiency in elderly care. So one team investigate 361, around 88% out of 411 recipients accepted for renal replacement therapy in six renal in six in six renal units, renal units across the southwest region in the United Kingdom between the 1st of June 1996 and the 31st of May 1997. The team demonstrate or informed that 124 recipients, around 35%, were referred within 4 months of renal replacement therapy, where renal replacement therapy is and was at a time for the recipients critical, and 84 around 23% within 1 month. 1 month between patients or patients later where patients were later referred to an other where within 1 month between patients that were later referred were later referred. The main differences between patients referred later and other patients or recipients were seen for those referred within were seen and sort of almost similar to those who were referred within 1 month. The elderly had more comorbidity, significantly inferior laboratory parameters at the onset of renal replacement therapy, and were less likely to have received standard chronic kidney disease care and CKD care, and had less lasting hemodialysis for example, in place at the onset of renal replacement therapy, 18% versus 47%, and had longer durations of infirmary time, 18 days versus 10 days, and 74 74 recipients, around 19% of recipients had died during the first 6 months. 27 around 32% in the 1 month cohort in around the 1 month cohort, and where 46 recipients, around 16%, in the 1 month cohort in all others. So higher morbidity and reduced survival rate. And reduced survival rate. This correlates with or had been correlated with late referral. The in part of a sort of additional works within the same sort of time period. One team performed a systematic review meta-analysis and exploring the early detection and cost effectiveness. 12 randomized angiotensin converting enzyme inhibitor, or ACI, investigations in 1900 in 1943 recipients with variable degrees of hypertension and proteinuria, showed the risk of developing renal insufficiency could be lowered from 30% over a 2 to 3 duration in a primary care on a primary care basis, on a primary care excuse me, on a primary care basis, and sort of model primary care model basis, comprising number one implementation of a single protein dipstick test. Number two, a 24-hour protein urine investigation, and three, the start of angiotensin converting enzyme inhibitor in suitable individuals. 20,000 people over the age of 50, over the 50, would need to be screened to avoid one case of renal insufficiency, according to a systematic review and meta-analysis that took place in around the time period around the time period of between in around the time period of around 2002. In around theme 3 now, looking at theme 3, so polypharmacy, dose adjustments, and medicines management in elderly care. So a retrospective investigation was conducted by one team to investigate referrals within 3 months within 3 months of renal replacement therapy. So there was in Group A there was 18 compared to references to 2 years later. Group B, where Group B had 50, where there was 50 participants. The number of patients stable, around 28%, for mild to moderate CKD or chronic kidney disease, where the acronym or abbreviation MMCKD was used, whereas seriously chronic kidney disease, where serious chronic kidney disease or where the acronym or abbreviation CKD was used. Group A around 44%, and Group B where Group B at around 20% was noticeable, and there was a shift from SCKD to recipients referred in MMCKD. Group A around 28%, and Group B around 52%. The investigators elaborated the significance of increasing accessible resources of main care to prompt referral of specialists. This includes medicines management, reducing unnecessary polypharmacy through for example, at the time in regard to medicines administration sort of records implementation would and could reduce the impact of potential renal insufficiency in elderly care. This in turn also reduces the burden on test requests and overall reducing costs in the NHS, in the National Health Service as a whole. Now in regard to theme 4, technology integration to identify renal insufficiency for elderly care. So in a United States investigation or US investigation, one team conduct a case sampling strategy exploring primary care practice. The team investigated primary care practices and knowledge surrounding renal insufficiency. Semi-structured interviews were also undertaken, and 10 randomly chosen practices were involved. Six topics were recognized. Number one, absence of guidelines. Two, desire for more guidance on renal insufficiency. Three, implemented appropriate screening at a timely manner. Number five, variability in treatment decisions, and six, uncertainty in patient referral times. Primary care has an important role to play where overprescribing and disease prevention is concerned. Medicine's management is sort of integral to monitoring renal insufficiency. So there must also be good interoperability to achieve a smarter workflow, and there is still a requirement for intuitive tech in context of use. Now, in regard to theme five, biomarkers to detect renal insufficiency in elderly care. So it is important that strategies are developed to prevent renal insufficiency in elderly care. CKD stages three through four in particular, is or are not always associated with, for example, an increased albumin creatinine ratio or ACR excretion, and this is where screening for low glomerular filtration rate or GFR could be imperative. In one investigation, excuse me, in one investigation, sort of survival rate analysis investigation, one team sought to explore or investigate early referral from primary care to nephrology and within the nephrology specialism for timely hemodialysis treatment. 366 recipients with CKD with chronic kidney disease and cardiovascular sort of and sort of cardiovascular cardiovascular sort of complications started hemodialysis between 1983 and 2003, and survival rate was followed up until 2005. Survival rates post initiation of hemodialysis was better in the early referral group. Age and pre CKD and cardiovascular function has and can have an impact on survival rate or prognosis. The smarter technology would prompt CKD screening and reduce unnecessary polypharmacy. In regard to theme six. So in regard to theme six and the role of education and healthcare professionals for elderly care. So one review had found allied health professionals or AHPs face varying encounters dealing with multimorbidity, including polypharmacy challenges caused by fragmented healthcare services and tech barriers to shared decision making in the provision of patient-centric care, and the complexity of following of guidelines in around guidelines, providing staff sort of centric guidelines surrounding kidneys or in around kidney care is important owing to the changes in health and disease over time, and primary care staff should also sort to keep up to date with aspects that surround elderly at risk and consult guidelines to meet best practices. It is good practice to ensure renal function and medicines used, for example, are routinely reviewed with primary care physicians and other qualified allied health professionals or AHPs. Overprescribing and disease and sort of disease monitoring differ globally, and this has been the case over over two decades. Now, in regards to in regards to critical analysis, so prevention of renal insufficiency centers around sort of primary conditions, primary conditions, uh, and there has been controversy over the advantage of particular guidelines, and this no longer in amongst particular guidelines in amongst particular guidelines there are a specific particular along particular guidelines, certain recommendations are no longer have veracity in line to, for example, the National Institute of Clinical Care and Excellence, due to insufficient evidence. Preventative measures are important, as the prognoses for those with advanced renal disease have been shown to be insufficient. So, for instance, in one investigation, 89%, around 189 out of 210 of a study group had died or required a form of renal replacement therapy within 3 years. Long-term therapies with doses of angiotensin converting enzyme, or ACI, can hold, for example, can hold symptomologies around hypertension, and decrease proteinuria and titers around hematocrit. The investigation from around 2005, into 2005 investigation informs of how resources can be rationalized, reducing polypharmacy. Renal disease progression may and can, or data around the data can improve, which should translate into less demand for particular sort of treatments, and thus provide alternatives to, at the same time, provide alternatives to renal replacement therapy. Prospective investigations, however, are needed to recognize how health education, tech, and systems could be better integrated to support smaller data capture in medicines management, smaller data capturing medicines management, and in amongst sort of clinical and medical sort of practices. Joined up tech would prevent joined up tech would prevent polypharmacy in amongst the elderly. So now, looking at some recommendations and implications to practice. So there are obvious advantages having integrated electronic patient records linked to medication, medical histories, laboratory investigations. Having data algorithms and smarter links to NHS services will and should highlight could highlight when elderly will require follow-up. Preventing unnecessary polypharmacy, implementing sort of inventive medicines management is again a part of an integral part of elderly care, and identifying prescriptions and dispense and administration routines will help understand, number one, whether, for example, pharmacists should be providing more effective medicine use reviews for elderly. Number two, whether healthcare scientists would find it more appropriate to receive screening investigations or requests for cystatin C complementing creatinine and 3, which elderly should be referred more timely to secondary care owing to renal insufficiency. Steps in dealing with renal insufficiency also include number one, identifying and screening elderly at risk smarter. Number two, ensuring elderly are not overprescribed, and treating conditions associated with renal treating conditions that are affiliated or associated with renal insufficiency, including low hemoglobin and or anemia. So ensuring at the same time ensuring at the same time that medicines doses or dosages and fluid intake and fluid intake and fluid intake are important, and at the same time where in amongst and between healthcare sectors and between healthcare sectors that where group where between healthcare sectors where for example, group consultations take place or can take place. This can help a more can help prompt or encourage a more patient or healthcare service user centric sort of care plan. So now looking at some conclusions as part of this works. So medicines management tech that integrates between systems is and can be important. Medicines use reviews and laboratory screening should be implemented for best practice. Polypharmacy prevention in elderly care needs to be a focus, especially if guidelines continue to prompt medicines use reviews and renal screening methodologies. When prescription of an angiotensin converting enzyme inhibitor or angiotensin 2 receptor blocker exists, potassium should be monitored before commencing therapy within 2 weeks or a fortnight after initiation and after the dose has been increased. If a recipient's creatinine or serum creatinine is more than 20%, it should be rechecked and discussed in amongst primary care. Inability to excrete or excess fluid and acid eventually compound general pathophysiology or physiology. Whilst renal insufficiency terminology also closely interconnects to kidney injury, it is important to appreciate that CKD stage 2, chronic kidney disease stage 2, is clinically significant, but underreported. Policymakers should continue to view polypharmacy as an ongoing concern, and education should be patient-centric in any population. And there is scope for education service development and initiatives focusing on allied health professionals or AHP involvement, but there needs to be coordinated effort between healthcare service providers to understand where this can complement and improve chronic kidney disease or CKD and CKD care aligned to healthcare services and healthcare service provision. In the research poster presentation, there is an outline of two different schematics looking at where one of the schematics looks at a pathway for a pathway in regard to point of care education, or POCE, and a second schematic looks at sort of tech and technology or online space guide for advice and educational support. Finally, in regard to and as part of the conclusions, some of the common causes of estimated glomerular filtration rate changes. So the common causes, where there's reversible and there's reversible causes of estimated glomerular filtration rate decline, and there's common causes of renal insufficiency. So the reversible causes of estimated glomerular filtration rate decline include renal tract infection, fluid depletion, nephrotoxins, nephrotoxins, and where nephrotoxins sort of additionally including pharmacotherapy such as trimethoprim, cimetidine, which raises creatinine, but does not at the same time does not reflect the true sort of fall in glomerular filtration rate, or GFR. In regard to the common causes of renal insufficiency, include IgA nephropathy or glomerulonephritis, polycystic kidney disease, or PKD, in at least where specific in hereditary renal disease or kidney disease exists, and in around abnormal arterial blood pressure, in around abnormal arterial blood pressure, in amongst other primary conditions. The full publication in around this research poster presentation is and was published in JOKC, and so in JOKC, and was and will, and as part of this audio podcast, there will be a list of citations where listeners listeners out there who would like to find out more can identify through the literature that will be listed for further works. That draws this audio podcast to a close. This audio podcast as part of a Biome edition. This audio podcast as part of a Phantom Newscast. This audio podcast as part of a Lobostics Vortex, and this audio podcast as part of a Storm Lobostics production.